Hello, my name is Hector Vasquez. I am a pharmacy intern at Albany College of Pharmacy and Health Sciences, currently doing my rotation at Champlain Valley Physician Hospital in Plattsburgh, New York. Today I will be talking about non-benzodiazepine options for alcohol withdrawal symptoms. We'll be going over the etiology, epidemiology, and options that are used in the setting of alcohol withdrawal. As stated in the intro, our objectives will be to go over the etiology and epidemiology of alcohol misuse, withdrawal syndrome, the pathophysiology of alcohol withdrawal syndrome, treatment options, risk versus benefits, and the place in therapy of all the drugs we're going to be looking at. Let's discuss the etiology. Although the pathogenesis of alcohol use disorder is not strictly known, several factors are thought to contribute to its development. These include environmental influences, home environment, peer interactions, genetic factors, the level of cognitive functioning, and certain existing personality disorders. Some of the genes suspected include the ones shown here on screen, and personality disorders associated with the development of an alcohol use disorder include disinhibition and impulsivity type disorders, as well as depressive and socialization-related disorders. In terms of the epidemiology, alcohol use disorders are the most prevalent of all substance use disorders worldwide. The single-year prevalence globally has been estimated to be over 100 million individuals. Additionally, nearly 3 million deaths, that's 5.3% of all deaths globally, and 85,000 deaths a year in the United States have been attributed to alcohol-related mortality in a single year. Psychosocial interventions are effective in the treatment of alcohol use disorder. However, as many as 70% of individuals return to heavy drinking after psychosocial treatment alone, meaning that this alone isn't enough. In terms of the pathophysiology, it is not entirely clear why some individuals suffer more from severe withdrawal than others. Some evidence suggests that genetic predisposition may play a role. Withdrawal usually does not occur in the general population, because most people drink in an episodic fashion. That does not lead to sustained high blood concentrations of alcohol, necessary to develop tolerance and withdrawal. Symptoms of alcohol withdrawal occur because alcohol is a central nervous system depressant. Alcohol simultaneously enhances inhibitory tone via modulation of gamma-aminobutyric acid, GABA, and inhibits excitatory tone via modulation of excitatory amino acid activity. In the patients with alcohol dependence, only the constant presence of ethanol preserves the homeostasis. Abrupt cessation unmasks the adaptive response to chronic ethanol use, resulting in overactivity of the central nervous system. As previously mentioned, GABA is a major inhibitory neurotransmitter in the brain. Highly specific binding sites for ethanol are found on the GABA receptor complex. Chronic ethanol use induces an insensitivity to GABA, such that more inhibition is required to maintain a constant inhibitory tone. As alcohol tolerance develops, the individual retains arousal at alcohol concentrations that would normally produce lethargy, or even coma in relatively alcohol-naive individuals. Cessation of alcohol or reduction from chronically elevated concentrations results in decreased inhibitory tones. Going over to the excitatory amino acids, glutamate is one of the major excitatory amino acids. When glutamine binds to the N-methyl-D aspartate, known as the NMDA receptor, calcium influx leads to neuronal excitation by binding to the glycine receptor on the NMDA complex. Ethanol then inhibits glutamate-induced excitation. Adaptation occurs by increasing the number of glutamate receptors to maintain a normal state of arousal. Cessation of alcohol, or reduction from chronically elevated concentrations, results in unregulated excess excitation. Dopamine too appears to be involved in both alcohol dependence and the manifestations of withdrawal. Increases in dopamine during withdrawal likely contributes to hyperarousal. A diagnosis is made when a problematic pattern of alcohol use leading to clinically significant impairment or distress as manifested by at least two of the following occurring within a 12-month period. Alcohol is often taken in larger amounts or over a longer period than was intended. There is a persistent desire or unsuccessful effort to cut down or control alcohol use. A great deal of time is spent in activities necessary to obtain alcohol, use alcohol, or recover from its effects. craving or a strong desire or urge to use alcohol, recurrent alcohol use, resulting in a failure to fulfill major role obligations at work, school, or home, continued alcohol use despite having persistent or recurrent social or interpersonal problems caused or exacerbated by the effects of alcohol. Important social, occupational, or recreational activities are given up or reduced because of alcohol use. Recurrent alcohol use in situations in which it is physically hazardous. Alcohol use is continued despite knowledge of having a persistent or recurrent physical or physiological problem that is likely to have been caused or exacerbated by alcohol. Tolerance, as defined by either of the following. A need for markedly increased amounts of alcohol to achieve intoxication or desired effect, or B, a markedly diminished effect with continued use of the same amount of alcohol. Withdrawal as manifested by either of the following. A, characteristic withdrawal symptom for alcohol, or B, alcohol is taken to relieve or avoid withdrawal symptoms. Complications related to this are minor withdrawal symptoms that are due to central nervous system hyperactivities. These include insomnia, tremulousness, mild anxiety, GI upset, anorexia, headache, diaphoresis, and palpitations. Symptoms are usually present within 6 hours of cessation of drinking and often develop while patients still have significant blood alcohol level concentrations. If withdrawal does not progress, these findings usually resolve within 24 to 48 hours. Specific minor withdrawal symptoms in each patient typically are consistent from one episode to the next. We can also see withdrawal seizures. Withdrawal-associated seizures are generalized tonic-clonic convulsions that usually occur within 12 to 48 hours after the last alcoholic drink, but reportedly sometimes occur after as few as 2 hours of abstinence. Seizures can occur predominantly in patients who have a long history of chronic alcoholism, as evidenced by their typical onset during the 4th and 5th decades of life. Withdrawal seizures are usually singular or occur as a brief flurry of seizures over a short period. Recurrent or prolonged seizures, or status epilepticus, are not consistent with withdrawal-associated seizures and should prompt an investigation into possible structural or infectious etiologies. These generally should be guided by the findings of CT or lumbar puncture. Although seemingly benign, alcohol withdrawal seizures, left untreated, can progress to delirium tremens in nearly 1/3 of patients. Another thing is alcoholic hallucinosis. Despite a tendency to equate alcoholic hallucinosis to DT, the two terms are not synonymous. Alcoholic hallucinosis refers to hallucinations that develop within 12 to 24 hours of abstinence and typically resolve within 24 to 48 hours. This is the earliest point at which DT typically develops. Hallucinations are usually visual, although auditory and tactile phenomena are also described. Patients are aware that they are hallucinating and are often very distressed. However, in contrast to DT, alcoholic hallucinosis is not associated with global clouding of the sensorium, but only with specific hallucinations, and vital signs are usually normal. The last one is delirium tremens. Clinical manifestations of severe withdrawal and delirium tremens are approximately in 5% of patients who undergo withdrawal from alcohol and suffer DT. DT is defined by hallucinations, disorientation, tachycardia, hypertension, hyperthermia, agitation, and diaphoresis in the setting of acute reduction or abstinence from alcohol. DT typically begins within 48 and 96 hours after the last drink and lasts for 1 to 5 days. Patients with DT have significantly elevated cardiac indices, oxygen delivery, and oxygen consumption. Arterial pH rises due to hyperventilation. This may be a rebound effect related to respiratory depressant properties of alcohol. Hyperventilation and consequent respiratory alkalosis in this setting result in a significant decrease of cerebral blood flow. There is a correlation between the length of the preceding alcohol binge, the degree of clouding of the sensorium, and the size of the average decrease in cerebral hemispheric blood flow, although there is no association between blood flow parameters and hallucinations or tremors. Severe alcohol withdrawal is often associated with fluid and electrolyte abnormalities. Almost all patients in acute withdrawal are hypovolemic because of diaphoresis, hyperthermia, vomiting, tachypnea, and decreased oral intake. Hypokalemia is common due to renal and extrarenal potassium losses, alterations in aldosterone concentrations, and changes in potassium distribution across the cell membrane. Hypomagnesemia is common in patients with DT and predisposes them to dysarrhythmias and seizures. Hypophosphatemia results from malnutrition, may be symptomatic, and, if severe, can contribute to cardiac failure and rhabdomyolysis. Some risk factors for the development of DT include a history of sustained drinking, a history of alcohol withdrawal seizures, a history of DT, age greater than 30, the presence of concurrent illness, the presence of significant alcohol withdrawal, and the presence of an elevated blood alcohol concentration, and a long period since the last drink, i.e., patients who present with alcohol withdrawal more than 2 days after their last drink are more likely to experience DT than those who present within 2 days. The best predicator for clinically significant alcohol withdrawal is a prediction of alcohol withdrawal severity scale, i.e., the PAUSE, with a score greater than or equal to 4. A timeline of alcohol withdrawal looks something like this. Without treatment by a healthcare professional, some people can progress from stage 2 to stage 3 very, very rapidly. While a precise timeline for alcohol withdrawal will be different from person to person based on several factors, some of these being average quantity, duration, heavy drinking behavior, the concurrent presence of physical and mental health issues, things like that. A general symptom timeline for alcohol detox looks like this. In the first 6 to 12 hours after the last drink, the relatively mild symptoms of early withdrawal may begin to be felt. These include headaches, mild anxiety, insomnia, small tremors, and stomach upset. By 24 hours, some people may have begun to experience visual, auditory, or tactile hallucinations. Within 24 to 72 hours, various symptoms may have peaked and begin to level off or resolve, though some of the more protracted symptoms may stick around for weeks or longer. Seizure risk may be highest from 24 to 48 hours after the last drink, requiring close monitoring and seizure prophylaxis. Withdrawal delirium, i.e. DTs, may appear from 48 to 72 hours after the drinking has stopped. Before discussing the pause, we will go over the more known scale, known as the Clinical Institute Withdrawal Assessment for Alcohol Revised Scale, or the CIWA. It is aimed at evaluating the severity of alcohol withdrawal symptoms. It consists of 10 questions with different answer choices, all weighing from 0 to 7 points. It can also be used for monitoring therapy of medications. Intervention with prophylactic medication should take place in the case of patients who score above 8. For patients who score above 15, additional PRN therapy should be added to traditional medications. Patients who score above 21 may carry hospitalization indication if outpatient management withdrawal is not possible. The newest method is the Prediction of Alcohol Withdrawal Severity Scale, or the PAUSE. This really is the best indicator and the best tool available for assessing alcohol withdrawal severity. It consists of 3 parts, all which are yes or no questions, and each question is worth 1 point. The questions can be seen here on this slide for a maximum score of 10. A score of 4 or more suggests a high risk for moderate to severe alcohol withdrawal syndrome. Prophylaxis and/or treatment should be indicated in this scenario. Before we begin treatment, it's necessary to exclude alternative diagnoses. Alcohol withdrawal remains a clinical diagnosis, and it may be necessary to perform extensive testing, including lumbar punctures and CT scans, to exclude other diagnostic considerations with confidence. This is particularly true when the presentation includes altered mental status and fever. Conditions such as infection, trauma, metabolic derangements, drug overdoses, hepatic failure, and GI bleeds can mimic or coexist with alcohol withdrawal. A premature diagnosis of alcohol withdrawal can lead to inappropriate use of sedatives, which can further delay accurate diagnosis. Then we move on to symptom control and supportive care. Once comorbid illnesses have been excluded or adequately treated, the management of alcohol withdrawals is directed at alleviating symptoms and identifying and correcting metabolic derangements. Volume deficits can be calculated and replaced accordingly, or, if there is no contraindications, isotonic IV fluid can be infused rapidly until patients are clinically euvolemic. Thiamine and glucose should be administered in order to prevent or treat Wernicke's encephalopathy. Multivitamins containing or supplemented with folate should be given routinely, and deficiencies of glucose, potassium, magnesium, and phosphate should be corrected as needed. Initially, treatment should be IV, as GI absorption is impaired in many patients who abuse alcohol chronically. Some clinicians treat alcohol withdrawal with IV infusion of a combination of thiamine, folate, and a multivitamin in isotonic saline with 5% dextrose. The multivitamin gives it a yellow coloring, which makes it gives it its name known as the banana bag. This treatment has not been well studied for clinical outcomes, and it may not meet the specific requirements for fluid, but giving it is better than not having it, and it'll lead to at least doing something with the patient. During the early phases of moderate to severe withdrawal, alcoholic patients are often given nothing by mouth, i.e. their NPO. This is to prevent aspiration. However, nutritional support is essential in alcoholic patients, and they are frequently malnourished and have high metabolic needs due to their excited autonomic state. Initially, parenteral glucose supplementation is sufficient, but additional nutrition is needed for patients who remain unable to eat for more than a day or two. Patients considered at a high risk for complications should be monitored in the ICU. We will quickly go over drug selection of benzos as they are the first line treatments, and it's good to cover them even though they aren't the focus of this presentation. So normally the ones used are diazepam, lorazepam, chlordiazepoxide, and oxazepam. In general, long-acting benzos are with active metabolites, those being diazepam or chlordiazepoxide, are preferred because they seem to result in a smoother clinical course with lower chance of recurrent withdrawal or seizures. For most patients, it's recommended to use by a symptom-triggered approach. Patients at greater risk of complications may be appropriate for just front-loading the dosages, so just giving more at the beginning. Lorazepam and oxazepam are better when patients have advanced cirrhosis or acute alcoholic hepatitis, as these are less hepatically cleared, and the shorter half-life of lorazepam in the absence of active metabolites with oxazepam may prevent prolonged effects in oversedation. In contrast, chlordiazepoxide, having a relatively long half-life, can lead to oversedation in patients who have severe liver disease. Treatment with agents available in parenteral form, those being lorazepam and diazepam, may be necessary in patients who cannot receive any oral medications. Given the common occurrence of drug shortages, preferred agents may not always be available. Benzodiazepines exert their effect via stimulation of GABA receptors, causing a decrease in neuronal activity and relative sedation. Knowing that this is how they work, it's also one of their biggest drawbacks, as preventing seizures and preventing sedation, they can also give and cause more sedation and more seizures. Now, let's discuss our first agent, phenobarbital. Recently, there's been an increase in recognition that phenobarbital has advantages compared to benzodiazepines. Phenobarbital has been shown to be beneficial both for initial upfront loading and also for patients who have symptoms refractory to benzodiazepines. Over time, emerging evidence and clinical experience has led us to doubt whether benzos offer any advantage compared to phenobarbital monotherapy. Barbiturates have dual activity, simultaneously enhancing GABA activity and suppressing glutaminergic activity. This dual mechanism of action is well matched to the pathophysiology of alcohol withdrawal, making barbiturates theoretically superior to benzodiazepines. This power is observed in other neurologic disorders as well, i.e. seizures, who are often refractory to benzodiazepines but rarely refractory to barbiturates. There is no positive symptom which will not respond to a barbiturate. Regarding alcohol withdrawal, it is widely recognized that a subset of patients with severe withdrawal will fail to respond to benzodiazepines, yet they will subsequently respond to phenobarbital. Benzodiazepines are notorious for causing delirium. Lower doses of benzos elicit agitated delirium, known as a paradoxical reaction. Paradoxical reactions are more common in alcoholism, with a rate of 2% in this population. Unlike benzos, phenobarbital does not cause paradoxical reactions. This reflects on phenobarbital's more balanced inhibitory effect on the brain via the two neurotransmitters. This protects against disinhibition. Seizures are one of the most dangerous complications of alcohol withdrawal. Among the agents used to treat alcohol withdrawal, barbiturates probably have the greatest anti-epileptic activity. Combining this efficacy with the long duration of phenobarbital may provide patients with excellent seizure prophylaxis. There's little evidence regarding the relative efficacy of benzodiazepines versus barbiturates for alcohol withdrawal seizure. Some reports have found that the addition of primidone to chlordiazepoxide reduced seizure rate, but this suggests that in alcohol withdrawal, as with other causes of seizure, barbiturates offer anti-epileptic activity above and beyond that of what a benzo does. So really, the only drawbacks here would be that phenobarbital has some CNS side effects. However, these are very small and relatively innocuous. And in short, this is a very good medication that can be used in as monotherapy as long as more studies show up showing the efficacy of phenobarbital. Here we see the only available prospective randomized control trial that compares barbiturates to benzodiazepines for patients with severe alcohol withdrawal. 91 patients were randomized to receive IM diazepam or oral phenobarbital. To preserve the blinding of physicians and patients, all patients were treated simultaneously with IM injections and oral medications, one of which was a placebo. Although the study had substantial methodological flaws, barbiturates were found to be superior among the patients with the most severe withdrawal symptoms. 3 patients in the diazepam group were initially refractory to therapy, leading clinicians to unblind themselves. This is one of the drawbacks we were talking about. Overall, these results are consistent with our current recognition that a subset of patients with severe withdrawal will be refractory to benzodiazepines. Here we can see the use of phenobarbital as an added therapy to diazepam, but what if we excluded the diazepam altogether? What if we used the phenobarbital only? This is what phenobarbital monotherapy would look like. Phenobarbital monotherapy is extremely simple. It amounts to dose titration using a single medication. Phenobarbital has a half-life of about 3 days, so successive doses will accumulate in an additive fashion. The main requirement for using phenobarbital is patience, because it may take some time to reach effective level. However, this time investment is worth it, because once the therapeutic level is reached, there's little additional therapy that's needed. The main decision that needs to be made is whether the patient qualifies for initial loading dose of 10 mg per kg, ideal body weight. For most patients who are initially presenting with alcohol withdrawal, 10 mg per kilogram of phenobarbital may be given safely. This dose will produce a serum level of phenobarbital of about 15 micrograms per milliliter, which by itself isn't nearly enough to cause respiratory suppression. However, if the patient has any other active neurological issues or has received a significant amount of sedation medication, especially a benzo, there's a possibility that this dose could cause excessive sedation. When in doubt, it's safer to omit the loading dose and simply use an incremental IV phenobarbital titration. So let's go over our next option, that being carbamazepine. Carbamazepine works by inhibiting voltage-gated sodium channels and potentiates GABAergic neurotransmission. Carbamazepine has been shown to be superior in ameliorating global psychological distress and reducing aggression and anxiety compared to oxazepam. Carbamazepine has also been reported to be an effective alternative to benzodiazepines in the treatment of alcohol withdrawal syndrome in patients with mild to moderate symptoms. Carbamazepine also appears to decrease the craving for alcohol after withdrawal. Carbamazepine was also found to be superior to benzodiazepines in prevention of rebound withdrawal symptoms and reducing post-treatment alcohol consumption, especially in patients who had multiple repeated withdrawals. Carbamazepine use, however, has been limited due to its interaction with multiple medications that undergo hepatic oxidative metabolism, making it less useful in older patients and patients with medical comorbidities. Also, carbamazepine has not been evaluated for treating of DT. Carbamazepine has been used in Europe for over 30 years to treat alcohol withdrawal. It is non-addictive, possesses no prominent sedating effects or interactions with alcohol, and promotes a reduction in alcohol withdrawal symptoms. Oxcarbazepine is a New York anticonvulsant med. It was developed by a structural modification of carbamazepine to overcome the side effects associated with the carbamazepine's active metabolites. So let's go over some of the evidence. In 5 trials, carbamazepine demonstrated significant efficacy in reducing symptoms of alcohol withdrawal syndrome in the inpatient setting. A randomized, double-blind trial of 83 patients compared the effects of carbamazepine with diazepam on severe alcohol withdrawal symptoms for 7 days. That's our first case. Patients were assigned treatment with either carbamazepine for a maximum of 800 milligrams a day or diazepam with a maximum of 80 milligrams a day. Both treatments were found to be equally effective in managing withdrawal symptoms. For our second trial, 58 patients were admitted to an alcohol treatment center in a double-blind study to compare the effects of carbamazepine and oxazepam in severe alcohol withdrawal syndrome. While self-rated assessments of mood swings and signs decreased with both treatments, no difference between the groups was found. In a double-blind study, Malcolm et al., it compared the effects of carbamazepine with oxazepam in 86 patients hospitalized with alcohol withdrawal syndrome. During the 7-day period, patients received a daily fixed dose regimen of either oxazepam 100 milligrams a day or carbamazepine 800 milligrams a day, each in 4 divided doses. Alcohol withdrawal symptoms were assessed by CEWA and self-reported VAS scores, and they were significantly reduced with both treatments, although no differences were found between the groups. However, global distress scores were similar on day 3, but they showed significantly less psychological distress in patients treated with carbamazepine than with oxazepam by the 7th day. Now let's go over our next 2 trials. In a randomized, double-blind trial, Withdrawal et al. Evaluated the effectiveness of carbamazepine against clomethazole in treatment of alcohol withdrawal symptoms. Throughout the trial, clinician-rated withdrawal symptoms were not significantly different between the treatment groups. By day 6, study medications resulted in substantial reduction in all symptoms, except depression, which was present in about 60% of the patients in both groups. Visual analog measures of improvement showed no significant differences between the treatment groups. No seizure activities or DTs was discussed in the results of the study, sadly. An open-label randomized control trial was conducted in 127 patients hospitalized for alcohol withdrawal syndrome to compare the efficacy and safety of diazepam, clomethazole, with a combination of thiopuride and carbamazepine. No differences in patient histories of alcohol withdrawal, delirium, or seizures, duration of alcohol dependence, and baseline alcohol withdrawal scores were observed between the 4 medication groups. The study also found no differences in alcohol withdrawal scores between the 4 medication groups, but then our next study, which is not the one of the original 5s, Hillbaum et al. Studied the efficacy and tolerability of carbamazepine, sodium valproate, and placebo in 138 patients admitted for inpatient detoxification. As you can see here, the measures of reduction in symptoms of AWS were not conducted, so it's not included as our evidence for, but it's still good data to read and know that the trial was conducted. The third agent we'll be going over is baclofen. Baclofen is a specific agonist for the GABA B receptor. This receptor provides a negative feedback loop for the GABAergic system, thereby downregulating the GABA A activity and mimicking some of the effects of alcohol-induced action on the GABA A receptor. Baclofen was initially and is commonly used as a muscle relaxant, but has been found to have a positive effect on alcohol cravings and relapse prevention. Baclofen is mainly excreted through the kidney, and unlike benzodiazepines, has minimal liver metabolism. Therefore, the risk of toxicity in the numerous patients with alcohol withdrawal syndrome and impaired liver function is reduced. There's no way to predict the dose of baclofen required in advance. It's helpful that patients understand how variable the effective baclofen dose can be, so that they're not disheartened by lower doses that have little to no effect on their cravings, if that's what happens. Baclofen is given as tablets of 3 to 4 times a day because the effect only lasts 4 to 6 hours. The dose of baclofen needed for the full effect on cravings varies widely between patients, from 30 to 300 milligrams a day. Baclofen is started at a very small dose, and this is steadily increased until the patient feels that the cravings are well controlled or gone. Sometimes the cravings gradually reduce as the dose rises, but for other patients, there's little effect on the cravings until a certain dose is reached. That's when the cravings will suddenly switch off. There's no way to predict in advance what dose of baclofen will be needed for a patient. Most patients will need to continue to titrate up the baclofen dose. The easiest rate of increasing is by 5 milligrams per dose, so half a tablet every 3 to 4 days. From 30 milligrams a day to 45 milligrams a day to 60 milligrams a day, like that. In talking with the patient, it's usually easy to work out if all the doses need increasing or only some, by asking where the cravings are the worst. It's usually in the late afternoon. The side effects are usually mild and transient. The most common side effects of baclofen are nausea, dizziness, sedation, and sleep disturbances in the first few days after starting the baclofen. These and other side effects generally fade away over 1 to 3 days, but often reappear again if at further dose increases. It is unwise to increase the dose while still side effects are present. Simply just continue the same dose until the side effects are gone. Wait a few more days and then continue to titrate the dose up. Here we see an example of the initial baclofen dosing for alcohol withdrawal syndrome. So we see that the first 10 days it's a slow titration up. So half a tablet for the first day in the afternoon, then another 5 milligrams, and it keeps going up that way, adding in the evening if symptoms still persist. So this is the fastest way to get to the 30 milligrams a day dose, and after that we can start titrating faster, as it will know that the medication is tolerated, and we can start treating symptoms from there. The last agent we will be going over in depth will be gabapentin, and its second generation agent, the pregabalin. They work by having an inhibitory effect on voltage-gated calcium channels containing the alpha-2 gamma-1 subunits. There are two main studies that project favorably for gabapentin. The first one, where Stock and colleagues completed a randomized double-blind controlled study in an outpatient setting. Gabapentin was compared with chlordiazepine epoxide in 26 veterans with mild to moderate AWS. Gabapentin started at 1,200 milligrams a day, and chlordiazepine epoxide started at 100 milligrams a day, were administered according to a fixed dose taper schedule over 6 days, and the outcome measures included sleepiness, alcohol craving, and ataxia, in addition to the CWAR scores. There was no significant difference in AWS symptoms by medication. However, those in the gabapentin group reported decreased daytime sleepiness compared with those who received chlordiazepine epoxide. The second trial, was a 2009 double-blinded RCT by Myrick et al. They evaluated gabapentin compared with lorazepam in reducing symptoms of alcohol withdrawal in the outpatient setting. 100 were randomized to receive gabapentin at one of 3 different fixed-dose taper regimens, either 600, 900, or 1,200 milligrams a day, or lorazepam, starting at 6 milligrams a day, for 4 days, with symptoms-triggered rescue doses to treat breakthrough withdrawal. Patients were seen daily on days 1 through 5, 7, and 12. CWAR scores decreased over the first 4 days in all treatment groups, but the high-dose gabapentin group had the lowest scores with a continued downward trajectory, even after medication discontinuation. The lowest gabapentin dose, 600, had to be discontinued, as it was not showing any good effects. Both gabapentin groups had decreased drinking, reduced craving, and decreased anxiety compared with lorazepam during the active treatment days. The high-dose gabapentin group also reported better sleep, less daytime sedation, and better ability to work during follow-up than the lorazepam group. So what does all this mean? Well, in summary, gabapentin may be an effective pharmacotherapy in the treatment of mild to moderate but not severe AWS symptoms. Due to its limited abuse potential, decreased sedation compared to benzos, relative safety when combined with alcohol, and its potential relapse prevention and reducing hypertension, gabapentin appears to be a useful pharmacotherapy for alcohol-dependent individuals with mild to moderate AWS and may be particularly useful in the outpatient setting. Finally, we have these other medications. They're either adjunctive therapies, which means they're better used with benzodiazepine, so they're not a good alternative option, or they're just newer medications that are still being studied, and the data is not completely clear yet on whether they're actually good agents. So the first ones we're going to go over are adrenergic medications. Those would be anything that's like alpha-2 agonists, clonidine, propranolol. They alter the functions of adrenergic receptors and are thought to significantly improve symptoms of AWS, especially the autonomic symptoms. They reduce the elevated pulse and blood pressure. There's no evidence that these medications prevent or treat DT or seizures, and adrenergic medications are of value largely just as adjuncts to benzodiazepines in the management of AWS. The next agent is ketamine. It appears to reduce benzo requirements and is well tolerated at low doses. However, there's not enough published data. It's a promising agent, but it still needs to be studied. Along those lines, levetiracetam has also been tried, but that one's had negative results. It did not significantly reduce the benzodiazepine requirements of patients with AWS. Next, a review found that sodium oxybate, a sodium salt, is a useful option for treatment of alcohol withdrawal symptoms. The salt is approved in Italy and Austria for the same. Next, dexmedetomidine is a drug which acts on the noradrenergic system and is currently used in the US in the treatment of AWS in the emergency setup. So this is something we use in the ICU. It's almost always on critical patients. It reduces the need of benzos and is a promising and effective adjuvant treatment for AWS. Next, we have valproic acid. Out of all these, it significantly affects the course of alcohol withdrawal, and it reduces the need for treatment with benzos. These are really effective. However, valproic acid use is limited by its side effects. It's got somnolence, GI disturbances, confusions, and tremors. The main problem with these is that they are really similar to alcohol withdrawal symptoms, making it really hard to assess improvement. And then, to cap it all off, we have preliminary studies that suggest that neuroanticonvulsants, topiramate and zonisamide, that can treat AWS. There's been randomized single-blind placebo-controlled trials for these agents, and they observed CWA scores and self-reported, so AWSCs, and AWS in 127 alcohol-dependent males. Topiramate was administered at a fixed dose of 25 milligrams every 6 hours. Symptom-triggered diazepam was provided for rescue if study medications failed to suppress acute withdrawal symptoms. All active study medication arms, so topiramate and the zonisamide, significantly reduced observer-rated and self-reported AWS when compared to placebo, but not between drug differences. No drug differences were observed in these measures or symptom-triggered benzodiazepine administrations. So these are medications to keep an eye on for the future. In conclusion, to keep this short and sweet, phenobarbital has strong evidence. We only need a little more trials for it as monotherapy, but the evidence is there and it's really good. Carbamazepine also works, and there's a little worry with the side effects, but with a little work it can be fixed. Also, it needs more studies with severe alcohol withdrawal, also with DT studies. Baclofen also, although it's really slow to titrate up, it's pretty cumbersome. It seems to work. It also needs some studies with DT for severe alcohol withdrawal syndrome, but there's data there to suggest that it could work. And then finally, we have gabapentin. It's a viable outpatient option. It's been tested as for severe. It really doesn't seem to work as well with severe, but it's a really good for outpatient, mild to moderate. We need more randomized control trials that directly compare these agents against benzodiazepines for better data, and with that, we will be able to establish a better place in therapy for these medications. There's other adjunctive therapies that work. Again, they are better added onto benzodiazepines, so those are good to look into if you don't want to use as high doses of benzos. And finally, the outlook for non-benzo therapy is pretty promising. There seems to be enough agents out there to start doing a good job and start trying to not lean so hard on benzodiazepines. So, in conclusion, phenobarbital has strong evidence. It only really needs to be studied more as head-to-head against benzodiazepines, but the evidence is there and it's really promising. Carbamazepine works. There's some worries about its side effects, and it also needs more studies with severe alcohol withdrawal, specifically more delirium tremens studies, but it also looks pretty good. Then we have baclofen. Baclofen is also effective. It works mostly on mild to moderate, and it can be kind of cumbersome to dose, but it seems to work when it's used. Again, it's not to be used for severe, and it's really good for cravings and just the feeling of needing to drink. And then our last agent was gabapentin. Gabapentin is really valuable also with mild to moderate, specifically in the outpatient setting. It's been studied for severe. It doesn't really seem to be working well for severe, so it's best just to keep that as a mild to moderate treatment. And it being outpatient with really not a lot of good side effects, it's really good. Again, we just need more randomized control trials, just head-to-head trials against benzodiazepines, and that'll provide us with sufficient evidence that we need to place some of these meds and see where they fit in in the clinical structure. We also saw that there was many adjunctive treatments that some of them need more studies. Some just are just that adjunctive, just to be used with benzos and shouldn't really be used by themselves. Finally, the outlook is pretty promising. As we've talked about, some of these medications have already been started to be studied as monotherapy, and they seem to be working. It really is just a matter of giving them more time to shine and giving them more time in the sun, more exposure, more evidence, and that'll really, really provide us with a good place in therapy for these medications. And with that, we've reached the end of our presentation. I want to thank everybody who listened to this. I have put my references here. None of the information on the tables or on the slides is from me. I've cited my primary sources if anyone ever wants to watch them. And thank you for listening. I hope everyone has a great day. And once again, thank you.